otherwise known as a Gait Lab, and we are at Shriners Children's in Salt Lake City, so we're just local. So they asked us to come out and talk a little bit about what gait analysis is and what we do. So, and then Bruce is going to share some of the research work that we've been doing. So there's a lot, I know everybody is from around the country, so I just want to let you know that, the Gait Lab doesn't just exist in Salt Lake. We have a network of motion analysis centers throughout the country. So probably there's one in your area you might have to drive to a little bit, and everybody is welcome to be a patient there. We actually have a booth, Dora right here, she can wave. If you guys want more information about how to become a patient at Shriners, she's available to help get you guys connected with that. So who are we? What does a typical lab look like? In our particular lab, we have a biomechanical engineer, that's Bruce, myself, a physical therapist, and we have a lab coordinator. But that's just a small chunk of the team. The greater team that looks at the data that we collect and makes decision is comprised of our orthopedic medical physicians. So we have 2 that are medical directors. We have prosthetics and orthotic staff that come down to help review cases. And we also have a physical medicine or rehab doctor. That's that person that prescribes like baclofen and does Botox injections and things like that. So that person is in attendance. And then we also have a physical therapist from our rehab department. So somebody who's actually doing PT and treating children to help us with our decisions. So that's what makes up our team. And we are an accredited lab. So there's a big process that we have to go through to become accredited. But we were one of the first. And there's several throughout the system that are accredited. And this is just, if you go on and Google and want to learn more and see some videos from Shriners, you'll see this quote of, what we stand for. Our motion analysis centers combine state-of-the-art technology with highly qualified, deeply caring orthopedic specialists. And our work leads to exceptional care for children with conditions that affect their movement. So why do we do a motion analysis study? So I think our primary purpose is we're helping to plan for a surgical intervention. So it could be an orthopedic intervention, like a tendon lengthening or a bony surgery, or a neurosurgical procedure. So often we're seeing kids before a selective dorsal rhizotomy or a baclofen pump placement, or other neurosurgical procedures. So that's kind of like the bread and butter of what we do. We see them before, we help with the decisions of what surgery to do, or also just to serve as a baseline measure to see them back again. We also use our data to look at decisions with bracing and other orthotics, medical management, so whether we're doing baclofen or Botox injections or suggesting another medication, and then some rehabilitation recommendations as well. And then we like to evaluate the outcome of those treatments. So very often we have the luxury at Shriners to bring kids back 1 year post an intervention like a surgery and do it again and look at the outcome. And then we might serve that to further make other recommendations. We also like to monitor kids over time, so we know kids are growing and changing. May not need a surgical intervention, but we want to kind of monitor that, see if we need to make recommendations on bracing. So we'll see that as well. And then another big chunk of what we do and what Bruce does is research. So we are a large network. We all communicate with each other and often share data and have multi-centered studies going on. So that's another benefit of the Shriners and our motion analysis centers. So does gait analysis help? You'll get this a question. We get a lot from insurance companies. Why should we pay for this? We have a lot of data to show what we do works. Unfortunately, some insurances still view this as experimental and may not fund it, and that's why Shriners is great, because we assist with that coverage. But there's been some instrumental studies showing that with the use of gait analysis, sitting down with a team, that 52% of the time we change those recommendations. That's huge. It's like half the time they're going in with this set of surgery, and then we're making recommendations to change it. We had another study that was published showing that if the group followed the recommendations, they are 4 times more likely to experience a positive outcome. So that's pretty huge. And then another one showing that clinical gait analysis is associated with a lower incidence of additional surgeries. So we kind of reduce it. So we often make recommendations to do all these surgeries at once rather than doing it, multiple surgeries over time. So, we like to say, what we're doing works. If we could just get the insurance companies to buy into that, that would be helpful. But that's why we're lucky to be at Shriners. So who do we generally see? So typically our age range at Shriners is, for the gait lab, is 4 to 18. We have seen a couple of 2 or 3-year-olds. You'll see in a minute what we require of the child to do. So they have to, be a little older to be able to follow directions. Also, cognitively being able to follow directions is very helpful. And they are seen at Shriners all the way up to 18, but sometimes we'll see kids a little bit older, like 20 or 21. The most disorders that we see are neuromuscular, so kids with cerebral palsy, brain injury, hemiplegia, stroke. That kind of makes up the majority of the patients we see. And then we see other conditions. In general, if you see kids that in-toe or out-toe, don't have any other neuromuscular disorders, we see those kids too, like flat feet, knock knees, toe walking is another common one that we see. So what does it look like when you guys, when you bring your child to the lab? And I'm going to go over these in detail so you kind of know what to expect and what we do. So we do a history, an exam, we videotape, then we do this 3D motion capture, and we collect a lot of data on function. So what are history and questionnaires? So I'll sit down and go through the medical records. We have time to kind of comprehensively gather all that data, which is really nice. Then we also sit down with the family and ask all those pertinent questions, kind of verify, go over the birth history, what medications and surgeries they've had. And then a very important piece is finding out what concerns families and patients. We always ask the kids what their concerns are and what their goals are. And we actually have a formal assessment of the goals. So we actually want the families to sit down and think about it and actually write down what your goals are for walking. And then we use that when you come back, we give it back to the families and they get to see what they wrote and rate how they did on it. So that's very handy. And then a lot of kids are having pain. So we like to find out, where they're having pain, how much, how often. And then we have parents do some questionnaires. One is how to rate their walking function. It's called a functional assessment questionnaire, or the FAQ. Another one is the functional mobility scale, which is right up here. So often we have kids using different devices. So we want to know, like, at home they're walking around, but maybe when they go to school they need a cane, or a walker, and then maybe in the community they're using a wheelchair. So it's for a good idea for us to get kind of catalog what they're doing in the community and at home. And then we have the parents, and then when the child's old enough, fill out another questionnaire, asking a lot of questions about function, pain, happiness, participation, and that's called the Pediatric Outcome Data Collection Instrument. If you guys are pretty savvy looking at literature, you might see this in a lot of studies. It's called the PODSI. Then after we collect all of that, we do a physical exam, and so we do general things, height and weight. We take a lot of measurements looking at alignment and things that we plug into our gait model. We do a really pretty comprehensive range of motion assessment, how flexible they are in all the different hip, knee, and ankle and foot joints. And then looking at strength. So we look at strength in detail using a dynamometer, so we get some actual data and numbers to how strong they are. And then if any kids have any tone or spasticity, so tightness, we have a measurement scale that we use for that. So we'll assign them a number. And then we look at motor control. And it's another test where we ask the kid to isolate movements in their hip, their knee, and their foot. And we assign that a number. So we collect a lot of data that gets crunched into an exam sheet in a database. And then we move on to a video. So we do videotaping of walking, but we also like to videotape other important motor skills. So sometimes we'll videotape going up and down stairs or up and down off the floor if we suspect some kind of weakness with that. If they have difficulty with upper extremity, we don't necessarily do 3D motion of the upper extremity, but we like to videotape their active range of motion so we can get an idea of how much active movement. And that helps us with referrals to specialists for hand. So just a little idea of what it looks like. You can see our lab here. So we like to take a video of them walking from the front and a video from the side. You can see this boy has hemiplegia and he's using a cane. And on the one side, we have him in barefoot condition, and then the next one is in his brace. So if they use a brace, we'll have them walk in their brace. If not, we'll do a shoe But most of when we move on to the 3D data collection is barefoot. So that kind of gives you an idea what it looks like, and we have to have them walk in a certain walkway, so that's why it's kind of critical to be able to follow directions and be able to have, if anybody has a visual impairment too, that can be sometimes difficult. And then we move on to our 3D motion analysis. So this is where we're putting all these retroreflective markers on. And in our lab, we have 12 cameras around the room that are just tracking those markers. So it takes a little bit of time, more time to kind of assemble and put all these markers on. We have a specific protocol about where they go on different bony landmarks. Then we'll put on our what's called our EMG, so electric myography, and this is just on the surface of the skin. So we just lay them on certain muscles and kind of tape and wrap them on. You'll see this kid with some Coban. So we do 5 sets of muscles, that surface EMG. And we put all this on and then have them walk. And we have force plates in our floors that measure the joint forces and the powers as well as they're walking across. And then we do a foot pressure analysis as well. So we have a little walkway where they walk over. You guys have probably seen those Dr. Scholl's things some people go to. It's kind of an advanced one of those. Yeah. So this is what our foot pressure analysis looks like when we're done with our data. And we take a photograph of them just standing to see what their feet look like. So some kids are flat, or if they have a high arch, we're able to assess that. And then what I think is also important, not just what they're doing with walking, but how they're functioning, right? So we have various assessments where we look at that are standardized. So looking at their gross, and we can even do some to look at their fine motor skills as well, and their balance and coordination. So things like walking between lines, walking on one line, sit to stand, getting up and down off the floor. For more advanced kids, we'll do some running and hopping and jumping, and we have a standardized assessment that we use so we can track them over time. So once we collect all that data, and it can take anywhere from an hour and a half to 2 hours, kind of depending on the cooperation of the kid and how much bribery we need to use to get them to do it. What happens afterwards is you guys, the patient leaves and the family leaves, and then I sit down and crunch all that data. So I have to process it all. So these are, what those markers look like. They're like little circles here, and we play kind of connect the dots. And then I look through, a handful of trials and identify which kind of look like them. And we average all those files together and crunch all this data with the exam, the history, the functional outcome measures, all those questionnaires the families fill out into a giant report. And then we sit down weekly with that whole team that I was telling you about, and we take a good look. We watch the video, we look over the data, and we spend quite a bit of time. Some cases are easy, and some cases take quite a bit of time. We could spend anywhere from 30 minutes, sometimes even 45 minutes if it's a really difficult, challenging case. I have to say our surgeons are very diligent about and mindful, considering families' goals and everything like that when we're making these recommendations. So often kids are referred by other physicians in the community, so we take those recommendations and we send them off to the referring physician. And then the referring physician looks at those recommendations and calls the family and discusses what the plan is from there. So before Bruce gets into some of the research, you guys have any questions? I know a few people may have had a gait analysis before, so you have some experience. Yeah?
Brief question on, you mentioned when you're post-eval that you bring the families back.
Yep.
Is that for a full secondary analysis?
Yeah, we do all those measures again, so we can have a
one-time insurance?
Pre and post.
Or is that 2 separate insurance?
Well, the luxury of being in the Shriners system is we're able to do that because they're often not covered, and Dora can give you the real correct lingo on that, but we're able to do that within our lab.
Sorry to interrupt, is that Salt Lake City specific, or is that the Shriners?
The Shriners in general do that. Now, if you're outside the Shrine system in general, and some of them are able to function and get insurance to pay, like Denver Children's, Gillette Children's is another huge one, who've negotiated great contracts with their insurance company. Unfortunately, they won't pay for a post-assessment. So it's really a luxury to the Shriners kind of system that we're able to do that. Yeah. If there's like another procedure that they're considering, they'll probably pay for it, like sometimes kids have to come back and we need to reassess, and do they need something else Yeah. We find it really important. We're able to collect a lot of data, as you're going to see in what Bruce is able to do with research, and that's why it's important.
Thank you.
Yeah, another question? Yeah.
What's the timeline from a referral to actually getting into the lab?
I can only speak for Salt Lake, but usually I would say within a month or a couple of weeks, we're able to get kids in. Yeah. And then from there, like your assessment and when we, write the report and send it back out, we say anywhere for 2 to 4 weeks.
I have a quick question.
Yes.
I know without like going into detail and everything, it's hard. But so like my son is flat-footed, and then on the left side, his ankles are turning in on both ankles now. Is it better to get those in alignment at an earlier age versus later? Because we're having a hard time with that right now.
Yeah. I mean, obviously getting that assessed as soon as you can is definitely better for sure. So without knowing like the details, but there are like for some severe alignment issues that are bony related, they can do something called guided growth, which is important to do before the growth plates close. So that's why we would say, it's better to get always that assessed ahead of time.
That's what we're trying to do, and they keep pushing us off.
I think
Yeah.
even if there's nothing we would do at this point, it's really helpful to have a baseline, because then we can see you in a couple of years. We'll say, you're fine for now, but come back in a couple of years, and we can see if it changed. Did it change for the better, for the worse, or did it not change at all? So it gives us an idea of how it's progressing.
Did
Yeah.
everyone hear that response?
Yeah, so in general, we like to see kids for a baseline and then watch them over time, because things could get better and sometimes things could get worse, and we want to see that. And sometimes we'll have parents call. We always say, hey, call us if things look worse in 6 months or 12 months. We're happy to see you back.
Do we need a referral if our child is already in the Shriners system? My son is seen at an outpatient clinic we live in Hawaii, in Kona, and so they come over from Oahu, and he's seen in that clinic.
Yeah, so you would have to go to Sacramento?
To
ref-
someone to write the gate lab.
Yeah.
But if you're already in the Shrine system, you just need someone to put an order in.
From Shriners or?
Yeah, and then you would be referred to what would be Sacramento, right?
I'd prefer
For
to
the
come
gate lab.
here. We have family here.
Yes.
Oh, yeah. Oh, yeah.
Yeah.
Yeah, we'd be happy to see you. We'd love to bring the lab to Kona. That would be awesome. We'll have to work on that. Yes.
That is the downside about living there, guys. The
Yes.
resources are.
The only downside.
Any other questions about kind of the nitty-gritty details of what we do? Yeah.
So is all that's needed just a referral from a provider?
Yep, and we see in Salt Lake, so we have agreements with some of the other providers, like, there's Primary Children's Hospital that has some of the orthopedic doctors, or the physical medicine and rehab, or even the pediatricians. Or you yourself can just call up and say, hey, I want to be a patient, I want my kid to get evaluated in the gait lab, and we would set you up. We'd just make you a Shriners patient, you would see somebody in our clinic and then get seen.
And if you do it that way, who did the recommendations go to?
Good question. We would probably, you would get connected into our system, so you would see somebody within our system, like a physician's assistant or one of our orthopedists, if you didn't have one already. Or the pediatrician. We would ask you who you want the results to go to. Yeah.
Does there have to be a specific intervention you're looking at, or can you say, I'm really curious about my kid's gait, I want to know what's going on so I know what?
Yeah. Obviously, we love specific questions, but yeah, we really like to see everybody baseline if we can. It is at a younger age. It just is so important, because when say they come in when they're 10 and like, now my kid's crouching really low, we're like, well, what did they look like when they were 5? It would have been really helpful. So yes, that is a very good use of our services for sure. And we're happy to talk more, and Dora's happy to help you guys out as well. All right, Bruce is gonna talk some research.
So I'm at the disadvantage of not really knowing my audience, because we've never presented here before. Is the term hemispherectomy known by kind of everybody? So okay, good. Because I can tell you what I know about it in like 5 seconds, okay? So kids with intractable seizures, they magically somehow go in and take out a piece of the brain and help those seizures. But so Amy talked about our database, and we see a lot of kids with cerebral palsy who have some form of epilepsy or at least are diagnosed with some seizures and are on medications. We have that information, but that information is not in our database, like yes, no seizures or yes, no epilepsy. But because this was an epilepsy conference, I figured that we should kind of look at something to do with that. But we do have surgeries in our database, so I looked up who in our database has had a hemispherectomy. So I know those kids have epilepsy because they were treated for it with this, fairly, I'll say radical, but I don't really mean that in a bad sense, surgery, because they had their epilepsy was so bad they decided that they needed to do this particular surgery. So this is not a research study. This is just kind of like a data overview because we don't have an IRB for this. So it's just because we're presenting to this conference, I just decided to look at this, okay? So take from that what you will. So we found 26 individuals that we've seen over time in our Gait laboratory who had hemispherectomies. 24 of them with diagnosis of hemiplegia, one was diplegic, and one had a condition called cortical dysplasia. Those children were seen several times each, or at least some of them several times, for a total of 67 studies. Unfortunately, almost all of those were already after they had their surgery. And what we really like to do is to see kids before and after, as Amy said. Okay, we only have 5 of those individuals. So we're going to talk about kind of 2 different things, what we can do with the 26 individuals with the 67 studies versus the 5 with the 5 that we saw pre and post. So first of all, we'll look at the kind of the bigger group to see what can we say about these kids. And my expectation, again, not really knowing a lot about this procedure or even about this disease, is that, compared to your typical child who has a hemiplegia, that maybe these kids might be functioning a little bit lower in several domains because of their epilepsy and their seizures. So we look at a few things, and not to get too into the weeds in terms of what these things mean, but we look at something called the Gait Deviation Index, and really you can think of this as kind of like gait quality. So compared to individuals who are developing typically, how kind of far away, we have a metric we can say how far away from the typically developing kids these children are. So that's one thing we'll look at. And a difference of 10 points, this is a scale of 0 to 100, a difference of 10 points is considered significant. And we're going to look at that compared to children with hemiparesis who did not have hemispherectomies by age. So the blue line is the kids who didn't have them. And you can kind of see they're functioning at right around 80 or so points on that particular scale. And the kids who had hemispherectomies are slightly lower, but not within that 10-point threshold. So that's really kind of good news. They're not really functioning very much different at all on their hemiparetic side. Interestingly, though, and I did not expect this, when we look at their non-hemiparetic side, their quote-unquote good side, they're at almost the same level. And so for a kid who has hemiparesis, we really expect one side to be better than the other, but we're not really seeing that. And a lot of that could just be compensation, right? Because if you're forced to walk in a certain position with one leg, you kind of mimic that with the other leg, so you're more symmetric. But we don't really know. It's a question that really should be investigated further. Another thing we look at is motor control within the Gait study. This comes from those EMG, those little electrodes that we put on. They look at how the muscles are firing and the pattern they're firing with. And the more sophisticated or the more complex the firing pattern, the higher the number you get. And again, it's on a scale from 1 to 100. And so my inclination here is that I kind of expected maybe the kids with undergoing hemispherectomy would be lower, and they're really not. You get this kind of weird curve, and I attribute that to being just so little data in that particular group. Remember, there's only like 67 points in the red line compared to hundreds in the blue line, so it's kind of weird, but it's about the same. And then we look at the non-paretic side, and it's exactly the same, okay? So we really don't see any difference in their ability, their motor control ability between the two. How about walking ability after hemispherectomy? We have another scale, one of the measures that that Amy talked about in terms of the functional measures. The parents get to rate this. How well can my kid walk? It's a scale of 0 to 10, has some very detailed descriptors in there. And really the take-home message is there really are no different. The walking ability is really just the same as their peers. And gross motor function, this is measured by the therapist. Amy talked about this. It showed a picture of one of the kids trying to walk on a line. There are 66 different tasks that they do, and they all get rated by the physical therapist, and that gets put into another score from 0 to 100. We really like that scale. of how functional they are. And here we do see a difference of only 3 points in this measure. It's very sensitive, is considered important. And you can kind of see the kids with hemiparetic their hemiparesis not undergoing hemispherectomy are really about 10 points or so greater than the children who did have hemispherectomy. So they're functioning at a slightly lower level in terms of their gross motor skills. So again, that's things like balance, being able to squat, what other things? Hopping, jumping, all that kind of stuff, yeah. And then patient-reported outcomes, again, these are things that we ask the parents, and they report on the PODCI. Amy mentioned another 100-point scale, where a difference of 7 points now is considered acceptable. I'm just going to show a couple of these measures. PODCI Sports is one that's really been shown to correlate a lot with kids with CP and different interventions. Here we see that they are functioning just about at that threshold of 7 points lower, and really no difference in things over time. And then a global functioning measure kind of takes all the scores and puts them together, about the same kind of message. So in summary, looking at those 26 kids, 67 studies, what can we say? They do have slightly more involved kinematics, but it's particularly on their quote-unquote good side compared to their peers. But they have equal motor ability and equal walking ability. We did find some deficits more deficits in gross motor function, and some reduced scores in the patient-reported outcomes. But then the more important question is that because they had a hemispherectomy, or is it because they started out more severe than their peers? So again, we only have 5 individuals that we've seen pre-post, so it's really not a lot to be able to hang your hat on, but we can still look at the data and kind of get an idea, hopefully, of where it's trending. And the expectation would be that there might be some declines, right? That's just my gestalt. When I think about taking a piece of the brain out, I think, you know, maybe they're not going to be functioning quite as well afterward. And in fact, I have to admit, the first time I even heard of this surgery, I really wondered if they'd be able to walk afterward. You know, I knew nothing about it, and right, exactly. That's where I was too. I mean, I'd been doing this probably for 10 years or 15 years when this was mentioned to me, and like, this kid is going to have a hemispherectomy, and I'm like, what is that? And then they told me, and I'm like, that blows my mind, you know. I mean, I can't believe they're going to do this. Like, is this kid going to, you know, be bedridden afterward, whatever? But to me, I'm still pretty amazed by this whole thing. So that was my expectation. And so we'll look at the gait stuff again, and the patient-reported outcomes, and the function that I've already introduced in that first set. I better use a different key here. I'm not having a little luck. Okay. So I'm going the wrong direction. Here we go. Okay, so gait changes. So we look at speed as one measure, okay? So what happens? We maybe expect a decline in speed. All the stuff in the red is the paretic side, so the side that should be affected. And then the stuff on the right is the non-paretic side. So let me go back up here because I got past speed. Of course, speed, you don't have a speed on each side. You only have one speed for the individual. So we do see some speed changes, some in the positive direction, faster, some in the negative direction, slower. But overall, it's a wash. And when you consider what the typical variance is, so like how much does any kid change over time, it's right within that threshold. So really, what we can say is their speed doesn't change after hemispherectomy, at least in these 5 patients. Okay, that gait deviation index, again, the quality of their gait. Again, a 10-point difference would be considered significant. We see a couple of those. So on the side that we would think we'd see changes in, we see some positive changes and some negative changes. So it kind of washes out again. And same thing on the other side as well. So we see some changes, but nothing huge. And again, overall in those 5, it's about a wash in terms of whether it changes or not. Okay. And then we look at the dynamic motor control. Again, that's the how complex their firing pattern is when they're walking from their muscles. Here we see a drop, okay? And to me that made sense, that you would lose some ability to finely control your muscles if they take out a portion of that side of your brain. But again, there's only 3 subjects. And then remember, when I showed what it looks like after hemispherectomy, there was really no difference. So is it dropping? I don't know. We only have 3 subjects, but it was something that we would look into more in the future when we get more data. And then functional outcomes, again, that gross motor score, where we're looking at all those different tasks. Again, we might expect that to decrease, and it doesn't in these 5 patients anyway. Kind of see it just remains very stable over time, or within that group. And then strength is another thing we measure that Amy mentioned. We do this with a dynamometer, so they kind of push against this device that measures how much force they produce, and don't worry about like what the data shows, but at 0 here, which is kind of right along there, it kind of shows that they're not changing, okay? Some positive, some negative. Again, we have very limited data for this, again, there's only 3 patients that had this particular test done pre and post, but you can kind of see it's all kind of a wash in terms of, is their ankle stronger, is their knee stronger? A couple of them went up, a couple of them went down, but none of those scores are really huge. So the answer to that would be their strength pretty much stays the same. And then, go back. Okay, sorry, go the wrong direction. Okay, strength, and then patient-reported outcomes for the functional, the FAQ, that's that scale from 1 to 10. You can see 3 of the patients reported no change in function. 1 of them went down 1 level, and 1 went up 2 levels. So again, not a lot of change there. Then here's the PODC data. This is all the scores we do. So there's a happiness, a pain, sports, transfers, and upper extremity. And then that's all combined into a global. So again, this is what the parents report in terms of how they're doing. You can kind of see there's positive changes in almost all those domains. Small changes, but again, they're all positive, and a change of 7 points would be considered a good change or a bad change, depending on which direction it's in. So you can kind of see some positive changes, especially in upper extremity, and in global, and in sports and comfort, and somewhat in pain. Okay, and then the last one is the goal attainment score. Again, this is where the patients and the families get to make up their own goals, and then they rate them back. And overall, again, we only have 3 that had this pre and post. The goals were met, so that's a good thing. Okay, so summary of the changes from those 5 individuals, and again, the hardest part about this is there's only 5. We didn't see really any consistent changes in overall gait and speed or gait quality. Their function by the GMFM remained stable. And then we saw mostly mostly favorable changes in patient-reported outcomes. Their walking ability didn't change. We saw some good improvements in the PODC, and the patient family goals were met. But again, we need more data to be able to say anything about this. So I thought I'd end with a couple of case studies. So all that data, hopefully, maybe we look at the individual, it makes a little bit more sense. So our first study was a 9-year-old female who had right hemiplegia. She's a GMFCS1, which means she's at the highest walking ability of the kids with cerebral palsy as they get ranked. Her GMFM was 81, so right about when I showed that original curve of those 26 patients, she's functioning right at that curve where we saw all those patients, which is the 23rd percentile for that particular group. And she has a GDI of 68, which means she's like 3 standard deviations from typically developing, so not too bad. And dynamic motor control was essentially normal. Okay, a 90 would be considered within the typical range. Ah, come on now. Okay, so here she is. And what we can take away from her walking, if I can get this one to play. There we go. So really a very typical hemiplegic gait. You can kind of see on her right side, she doesn't have a lot of knee flexion. You can sit up on her toes. Not too much in the frontal view that you can pick up on, other than she's a good hopper. Some deviations there, but nothing too severe. So we saw her again. She had her hemispherectomy. We saw her 4 years after her that initial study, and almost 4 years after her hemispherectomy. And the changes that we saw was her gait quality increased by 11 points, so that's a significant change. Most of that, by looking at the curves, came from improvements in her ankle joint. Her paretic side decreased in her dynamic motor control by 18 points, which is a huge decline. Very unexpected, and it doesn't make any sense that her gait quality went up, but her motor control went down. Those things usually go together, okay? So it's very interesting, right? I mean, I don't really understand it. Again, it's just one case, so we need more data. But then in a later follow-up, it wasn't so bad. She went up another 7 points, so that means an overall decrease of 11, which is just about a, significant or not significant, so not a lot to hang your hat on. And she had some good improvements in her PODC scores. Her, in particular, comfort and pain went from a 58, which is fairly low, to a 75, which is pretty good. No changes in her gross motor function. And then with her goals were to reduce falls. She met that goal. Improve participation, exceeded that goal. Improve balance, exceeded that goal. And eliminate toe drag, which was unchanged. And then here she is afterwards. So we're going to show the preoperative again on the left and the postoperative on the right. So if you focus on the difference between those two, her feet are in a better position. That's kind of how she got a better change in her quality of gait index. But she looks a little smoother to me as well. But did any of those things happen because of hemispherectomy? I don't know. You're just happy that they don't get worse, right? I mean, that's kind of the take home of this whole thing. She looks at least as good as she did previously. Okay, and the second case study is a 5-year-old male, again with right hemiplegia, another high-functioning walker, as we expect in hemiplegia, really. His gross motor function was right about the same as the previous gal. Gait deviation index was approximately the same as well, and again, he had also had a very normal typical dynamic motor control index. So here's what he looks like walking. Not so much up on his toes as the last girl. Gets a little bit better knee flexion, I think, not quite as stiff. You can kind of see in the frontal view that right leg is pointed out quite a bit. Okay, so his experience. We saw him 3 years after the preoperative study, 2 years after hemispherectomy. His changes were his walking quality got worse by 9 points, which is about significant, but that was mainly due to that foot that was already out kept going outward, okay? Probably has absolutely nothing to do with the surgery that he had. Would have happened in any child with cerebral palsy. We see that a lot. Once they start out, it's a progression, okay? And that's why we do surgery. His dynamic motor control also decreased by a lot, by 11 points. So again, something that's very interesting. That one went with his decrease, but those things are probably not related in this case because we don't expect muscles to pull your foot out. His PODC scores, he got some significant improvement in almost all his domains. Okay, so the parents thought that he was doing much better after his surgery. And again, his goal attainment scores, he wanted to decrease pain, that was met, improve balance, that was met, and increase range of motion, which was unchanged. And then here's his pre-post comparison. And sometimes hard to compare, especially these kids. This one started at 5, right? All kids change if they did nothing done between 5 and 7, or or 5 and 8, where he is now. But again, it's a nice message that he's walking great, right? Okay. So case summary changes. So the changes that we saw in the gait did not really mirror other changes. In the first case, the GDI improved, but there was no change in function. In the second case, his gait quality decreased, but there was improvement in function. Changes observed are probably not likely due to the operation that they had, and we saw nice improvements in the patient-reported outcomes, including the PODC measures and their goal attainment scales. Well, that's all I have. Happy to answer any questions that you might have. I mean, the take-home message for me from this is we need to do more research in this and see more patients. Thank you.